Hi guys, we're going to cover diabetes type 2 this week. We talked last week about the glucagon insulin feedback system. We covered a little bit about diabetes type 1. We're going to go, so you kind of have to have an understanding of all of that stuff to understand diabetes type 2. So if you're struggling with, when we start talking about gluconeogenesis and glycogenolysis and all of that stuff today, if you're struggling, flip back to the video that I did on endogenous insulin and the glucagon feedback system, and it will help a lot. We talk about diabetes type 2. Remember we talked the other day about in diabetes in general, we have these kind of different things that are going on with the insulin, right? You can have an absolute insulin deficiency where you just have no insulin whatsoever from your pancreas. And you guys know now that that would be considered type 1, right? Sorry. And then you can also have an impaired release where your pancreas isn't producing as much as you need for your demand. And that can technically be, really, it could be a type 1 or a type 2, depending. And then we have where the body is making or has inadequate or defective kind of the insulin receptors. Remember we talked about over here that the glucose can't get through, can't get through the channel into the cell without insulin. The insulin has to kind of come and unlock that door. But if there's something wrong with this receptor here, I don't know, it's misshapen or it's just not, in the real world of molecules, I don't know that things are necessarily misshapen, but say it's, there's something wrong with it and the insulin isn't able to connect to it. And when that happens, then this little glucose receptor here never opens. And the cells have a number of these kind of insulin receptors on them. So some of them might work and some of them might not. And so that's how you end up with less insulin or less glucose being used in the system, but not necessarily a complete or an absolute deficiency like you have in diabetes type 1. And then our other option was that the insulin was being destroyed in the pancreas. So we have less supply available. And that has more to do with how the insulin is traveling in the body. Again, I would say this one is more, for our purposes, think of it as more type 1. It's just easier. So we're really focusing on these two things today. And we talked a lot about insulin resistance and insulin sensitivity when we talk about obesity and metabolic syndrome and how that affects, or quote unquote, insulin sensitivity. And I think sometimes people are like, oh, what are we talking about? And that's exactly what we're talking about. How the body is responding to insulin, how sensitive are these cells to the insulin that's around them, and how easily can they kind of attach, and so that those glucose channels are opened. So that's kind of just that's where we're standing. There's a little bit more to the etiology, so I'll go through it a little bit. I'm not going to kind of go through this kind of stuff. You can take a look at it on your own. So when we're talking about diabetes 2, we're talking about three main contributing factors. We have our insulin resistance. That's kind of just what we talked about. A decrease or an increase in insulin secretion. That kind of sounds confusing because you're thinking, well, if I have an increase in insulin secretion, how do I end up with high glucose? And we'll talk about how that happens later. But the reality is that you either have too little glucose or you have too much. But if you have, insulin, if you have too much insulin, it's probably a response to what's already going wrong in the body. And then the third is that your liver is just producing a ton of glucose. So remember, the gluconeogenesis and glycogenolysis are both, they both happen in the liver. One is breaking up the glycogen and turning it back into glucose. Remember, lysis and glycogen, right? And then the other is actually coming up with or building new glucose. That's why you've got gluconeogenesis in there. And then, yes, there can be an alteration in hormones and adipokines that are normally released by adipose tissue. We'll actually talk a little bit about that as well. So we talked about type 1 being fairly genetic, right? And talked about some of the ways people can be susceptible to type 1. Type 2, there is a lot of evidence that it is a genetic problem as well. We mentioned this last week as well about something being polygenic, meaning it's like one kind of characteristic, like eye color, hair color, or insulin resistance or whatever, that's controlled by a number of different genes. And so that makes things a little more complicated when we're trying to figure out or pinpoint exactly what the genetic pathway is to controlling these genes. Environment and social determinants of health have a huge effect on type 2 diabetes, because type 2 diabetes, while there is a genetic component to it, much of the cause of or the etiology of diabetes type 2 are things like obesity, sedentary lifestyle, high stress, maybe even triggered by viral toxins. It's diet, it's exercise, it's all of those kinds of things. And we know from all of the amazing studying they've made us do in nursing school that there are certain populations and certain marginalized people people with low socioeconomic status, for example, who are much more likely to suffer from obesity, sedentary lifestyles, to suffer from things like depression, where they don't want to leave the house, to not be able to, or to not have access to healthy options in food, and so on. And so you can't take this out of the story at all. And in fact, one of the highest populations that struggles with diabetes type 2 would be Canada's Indigenous population. And so oftentimes you will see that on a test, you have seen an Indigenous person come in and, what should you be worried about? Always Indigenous Canadians are at higher risk because of their socioeconomic status, systemic racism and colonialism. You have all of these kind of like trickle down effects that have caused the population to have just much higher risk for all kinds of disease, and especially mental illness as well. So type 2 is much more common. Diabetes type 2, much more common than type 1. About 80 to 90% of all diabetics are type 2. And most of the time, patients are obese or overweight. You very rarely ever see like a very thin person with diabetes type 2. Adipocytes play such a big role in influencing insulin resistance. So let's talk a little bit about how like kind of how the order goes, I guess. Again, this is stuff that you're not going to need to know this for your NCLEX. You're not going to need to be able to, break down every step. But it's still really good to understand what's going on in the background, because it will help you answer the questions. It will help you to critically think and put things together. So in the beginning, you kind of have this relative insulin resistance, decreased insulin receptor signaling, impaired insulin secretion, all the things we've just talked about. And what happens is, because of that, your insulin, the insulin that your body is releasing, for example, is not being used. It's not, the cells aren't able to, they're not able to attach to the receptors, and so they're not allowing glucose to be used. So then what happens to the glucose? The glucose then is going to increase in the blood because it's just floating around in there and it's not being used. And so that's why you end up with this short-term compensatory hyperinsulinemia. Remember over here we talked about sometimes you're going to have like an increase in insulin. It's kind of strange, but this is what we're talking about. The body thinking, okay, well, it doesn't necessarily sense that there's so much glucose in the blood and it's just not getting in because of the insulin. It just thinks, there's so much glucose in the blood, we need to do something about it, and it just releases more and more insulin to try to deal with that, not knowing that really that most of that insulin isn't working anyway. And as time goes on, you end up with progressive beta cell impairment. We talked about the beta cells in the last video being the part of the pancreas that releases endogenous insulin. So slowly, as we have this hyperglycemia, hyperinsulinemia, for long, long periods of time, you end up with this kind of beta cell desensitization. It's just not making as much. I like the word here that's kind of burnout. Like it's burnt out. It's not making enough insulin anymore. And if you look back here, it kind of makes sense. It's been shooting out all this insulin here, trying to deal with all the extra glucose in the blood, thinking that this insulin is going to help. And it might help a little, but it's not helping enough. And it keeps going and keeps going and keeps going until it completely burns out. And now we have even less insulin coming out of the pancreas, and that's a real problem. So now you're going to end up with these decreased insulin secretion. The reason it says deranged in some of the books is because I think it's because it's referring to this, to how that's kind of happening. And so it'll say deranged as in out of range, not crazy, like deranged. It's like out of range, meaning sometimes it's high, sometimes it's low. But at this point, I think of it as, there's a decrease in insulin now because we've burnt out. Those pancreas cells just don't have it in them anymore to create any more insulin. And so that's where we end up with that impaired insulin. It's not coming out of the pancreas. And then as well, because of the insulin resistance, it doesn't have good uptake in the muscles. In the cells. And most of the time we are talking about in the skeletal muscles at this point. And then we end up even with further hyperglycemia. So it's just kind of a vicious cycle. We've got, the liver thinking, well, we don't have enough glucose. There isn't enough energy in the cells. So I must need more glucose. So it's creating more glucose. And then, you've got all this other stuff kind of going on over here with the insulin, and it's just a recipe for disaster, right? So there's this little kind of history of the development or the etiology of type 2 diabetes. Is a little bit different than what we talked about in diabetes type 1 because you have this kind of pre-diabetic part. And if you've ever, I don't know, like my dad is pre-diabetic right now. And they're just pushing and pushing and pushing him to like lose weight, take a walk, eat, less carbs or whatever, because you really can actually reverse what's going on. If you catch it during this time, you can change it without necessarily going on medication. But if you just look at this, it's kind of showing you, this right here, this line right here is showing you when the person is diagnosed. So they're actually diagnosed with diabetes type 2, but you can see that things are actually going on 10 years before that. That insulin resistance is slowly starting to build. And as it's starting to build, what's happening? Well, if you look down here at glucose, your glucose is going up because you're not able to use it. And then as that glucose is going up, at first, your insulin is actually going to go up with it. It's that compensation that we talked about. It's compensating for all of that glucose that's in the blood. But then you see this kind of moment where, the body goes, I can't keep doing this. This is way too much work to be creating all of its insulin. And those poor beta cells burn out. And now you still have, assuming we haven't done any treatment or anything, you still have that glucose kind of going up. And whether it's, postprandial glucose or fasting glucose, they're both going up. Now you're going to see that drop in insulin, which as the insulin drops, now that glucose is going to shoot right up. And so you end up with this right around here where you start to really feel things. You start to feel the difference. And this is where it's amazing, because this is where those microvascular complications I think we'll talk about today, or in another video, those microvascular complications are starting like 5 years before people are even being diagnosed. They're starting around when that pre-diabetes is now like, okay, we're not pre-diabetic anymore. We're actually diabetic. And many, many people will not go in because they don't necessarily have a lot of symptoms here until, you see this diagnosis is happening 10 years after the first insulin resistance has started, right? So this is just kind of giving you an idea of, the pattern of how it kind of moves. It's really just showing you this thing that we talked about earlier in a little bit of a different way. The onset of disease is quite gradual. It's 10 years of this kind of compensatory action before you're actually detecting this problem. We'll talk a little bit about that when we talk about all of the manifestations in a minute.